Assalamualaikum and a very good morning. Welcome to Breakfast at UMHealth live webinar series. My name is Mohammad Aizuddin and I'll be your moderator for the first talk for today. Ladies and gentlemen, colleagues and honored guests, it is my privilege to introduce Professor Muhammad Idzwan Zakaria, a leading expert in geriatric emergency medicine. Prof. Idzwan is a professor of emergency medicine at University Malaya and an active advocate for older patients in emergency care. His expertise in this field is extensive, and he served as chairperson of the Geriatric Emergency Medicine Special Interest Group for the College of Emergency Physicians, and also a representative for Geriatric Emergency Medicine Special Interest Group for the International Federation of Emergency Medicine. With his wealth of knowledge and experience, Prof. Idzwan will share valuable insight into how the clinical frailty scale can be a vital tool for assessing older patients. Please join me in welcoming Prof. Idzwan. The floor is yours, Prof.
Assalamualaikum and very good morning to all the participants to today's breakfast at UM. I'm going to talk about clinical frailty scale, CFS, clinical CFS, and I would like to promote it as a vital sign for the older person in our hospital and hopefully the whole of Malaysia. That was me at the Taiwan International Conference of Emergency Medicine last month, in which I was there to as a speaker as well as facilitator for both the workshop as well as conference proper. I'm part of the Geriatric Emergency Medicine Special Interest Group in the International Federation of Emergency Medicine. And I would like to acknowledge the GEMSIC IFAM for promoting myself to get a waiver for the conference, and also the assistance that I got from UMSC Care Fund and College of Emergency Physician Academy of Medicine Malaysia. Now, what are the definition of vital signs? They are a set of measurements that provide critical information about the physiological status of a person. They are essential in assessing and monitoring the overall health and detecting potential medical conditions. Yeah, so those are vital signs, the definitions. The current vital signs, the one that we are using here in Malaysia as part of the CPG, they are blood pressure, heart rate, respiratory rate, temperature, and pain score. And mind you, way back in 2008, Ministry of Health has put pain as the fifth vital sign. Then we also, as part of the patient safety program, University Malaya Medical Center has instituted the National Early Warning Score. And these involve the vital signs and also other parameters in order to detect deteriorating patients in our ward. Statistics in Malaysia has mentioned that the population of Malaysia will be 1 in 7 will be an older person in 2030. So we are going from an aging population to aged population. And in the emergency department, being the front door to the hospital, we will see a lot more older person coming to our emergency department. And our statistics shows that about 20% of our patients are more than 65 years old. And a study that was conducted by myself and my team way back in 2014, these patients being longer in the emergency, not because of the because of the numbers of investigations that we will be doing, Because of that, there will be a lot more older patients in our emergency department. The other thing is we need to have a objective assessment proper for the older person in order to look at the quality of life. So this is an example of older person coming to our emergency department, and those issues are currently being faced by not only in our hospital, but also in all other hospitals in Malaysia. Now, I would like to highlight the concept of geriatric 5Ms. And these are the core competency in management of older person. You have to look at the issues of mind of the older person to look whether they have dementia, delirium, or depression. You have to look at their mobility in terms of gait and balance, and also fall prevention. You have to look at their medications, whether they have a polypharmacy, optimal prescribing, and also adverse effects of this medication. You have to look at multi-complexity, which means the multiple comorbidity of these patients. And finally, what matters most, which is the individual older person own which goals and preferences. And these are the ones that we always tend to forget. Yeah, what matters most for the older person. The other thing that we clinicians in Malaysia tend to forget is the quality of life. And you not only in general. Okay, can you hear me better?
Okay, Prof. Now it's better, way better.
Okay, all right. I think the internet is a bit unstable. It came out in the Zoom just now. Right. So, is it a norm to be frail? Malaysian culture, yeah, we support filial piety, meaning we tend to care for our older person, and we don't mind how frail they are. We will actually ensure that they are being taken care of. And the other thing is that it is a norm in Malaysia to say that older person it's okay to be frail, yeah. But actually, we would like them not to be frail, yeah, because as I mentioned in my article, frailty is reversible if identified early in older person, and I hope people do actually accept that. Now, the management of older person. Just now we mentioned about the 5Ms of geriatric management, yeah, and we mentioned about frailty. Management of older person has to be holistic and personalized. They have to be individualized. And mind you, what matters most, we have to have a shared decision making for them. The concept of geriatric medicine, we have to identify the geriatric giants, yeah, which was introduced by Bernard Isaacs in terms of older person immobility, instability, incontinence, and intellectual impairment. And now we have the concept of geriatric syndromes to look at frailty, sarcopenia, multimorbidity, anorexia of aging, cognitive impairment, delirium, falls, urinary incontinence, yeah, pressure ulcers. Those are the things, and also polypharmacy. Those are the things that we need to look at. So what is frailty? Frailty is a clinical syndrome characterized by a decrease in physiological reserve, resulting in slowness, weight loss, impaired strength, exhaustion, and low physical activity, which leads to increased vulnerability to stressors. So basically, it is a clinical syndrome in which there is a decrease in their functional physiological reserve, and which means that they're very vulnerable, yeah, if they are severely frail, even to small stressors such as urinary tract infection. So that is frailty. It involves physical health, functional ability, cognitive and mental health, social and environmental circumstances, and quality of life. It need not be only physical health. Now, this is my medical officer's usual assessment in their documentation of the patient or in their notes. They always like to write activities of daily living, instrumental activities of daily living. Mind you, these are only the basic self-care tasks, and and if it is IADL, is more complex activities necessary for living independently. However, these ADL and IADL may not capture the full spectrum of frailty. Frailty is an aging process, but it is not inevitable. Yeah, it is not inevitable. Yeah, not all older person are frail. Yeah, it is not static. It can be made better or worse. I always look up at this concept of chronological age versus biological age. Older person we should not look only at their chronological age. We need to look at their biological age, in which how they are in terms of their frailty. Yeah. Look at Tun Dr. Mahathir. Despite being nearly 100 years old, he is not frail. Yeah, he's still driving, etc. So similar to Robert De Niro. Yeah, he is nearly 80 years old, but he's up and about and also participating in a lot of movies, acting a lot. So what are the complications of medication side effects? Malnutrition and weight loss, functional decline, social isolation and depression, higher mortality, and susceptibility to other geriatric syndromes. Frailty assessment, which one to use? In an article published by the JAMSIC of International Federation of Emergency Medicine, in Age and Aging in 2024, it is better to have a practical solution now than to wait for a perfect one. There are quite a number of frailty assessment. However, some guidelines prefer certain frailty assessment, other prefer the other. But this article mentioned that it is better to have a practical solution than to wait for a perfect one. And hence, we need to choose a frailty assessment which has a high validity and a high sensitivity and specificity. I would like to suggest the use of clinical frailty scale. All the participants, please open up your App Store or your Google Play and have a look at the clinical frailty scale app. It is free of charge. You can download it now. If you cannot remember anything of my presentation today, please download CFS, and it will actually assist you in doing a clinical frailty scale CFS and assess frailty of this patient. Yeah, it is actually developed by Rockwood et al. In Canada, and being developed by the National Health Service in the UK. If you don't actually download it, mind you, you can just look at this diagram here. And it shows that just ask the carer or the patient whether they stay indoors or outdoors. If they stay outdoors, they are not frail. Yeah, meaning they're able to walk outdoors. That's what I meant. They're able to walk, whether they are independent but slow, which is CFS4, or whether they exercise regularly sometimes or never. If they stay indoors only, they don't go out, they are frail, yeah, and whether they need assistance or not, depending whether never, sometimes or regularly. If they are bedbound, they are very severely frail. If they are approaching end of life, they are terminally ill. CFS has a good assessment and has been published in way back in 2020 in the Annals of Emergency Medicine. It is stated that CFS of 7, yeah, mortality is 50% after 1 year of ED attendance, and that is the outcome that one has to actually understand. Why do we need to have frailty screening? Because our usual protocolized pathway for a presentation of older person in emergency department is insufficient to manage this older person with frailty. That means they have to be individualized. We always use pathway, especially in terms of management of ACS, stroke, critically ill patient, yeah, etc. But for frail older person, we cannot use the usual protocolized pathway. Let's have a look at some of the guidelines in other fields which use or are using frailty. First, the European Society of Cardiology has come up with a management of older person who comes in with ACS, heart failure, and atrial fibrillation. They have incorporated frailty in terms of looking at frailty independent risk factor to mortality in ACS, and also frailty is identified when risk stratifying acute heart failure in emergency department or procedural related intervention, and the use of the newly oral anticoagulant. The and also the oral other oral anticoagulant. The in terms of STEMI management, the PCI is recommended for both older person and younger adults, and similar to non-STEMI in Europe. They are also looking at frailty in terms of medication advice, and also realistic expectation on prognosis in decision making. In America, the AHA has also come up with the management of acute coronary syndrome in the older adult population, in which they have incorporated the geriatric syndrome, and one of them is frailty, and they have suggested routine assessment of frailty such as CFS. In STEMI, primary PCI is safe, and in non-STEMI, risk evaluation between cardiovascular in terms of symptom control, bleeding risk, and non-cardiovascular such as the quality of life needs to be assessed before revascularization. They use frailty in the discharge planning, and also the frailty in terms of bringing in multidisciplinary care team, and they have suggested future clinical trials and observational studies to look at ACS management on patient with frailty. The pre-op assessment done by the geriatric surgical patient ACS best practice guidelines has also recommended the use of frailty assessment, and they have mentioned that frail patients are at much higher risk, but are using frailty score. The American Society of Colon and Renal CG in terms of evaluation incorporate use Frailty the and stable. How is it now? Aizuddin? How is it now?
Okay, bro.
Still break on. Okay, yeah. All
Now
right.
it's better.
Internet, okay.
Yes.
So,
Okay.
okay. So now they have mentioned about medication management. An example is that they have advocated for higher level for patients, older patients who are frail. Yeah. The cancer guidelines, the adult oncology featured in the NCCN guidelines has also recognized and suggested the use of frailty in older adults with cancer in terms of tailoring treatment plans and improving outcomes. Now, let's go back into our critical care as well of emergency medicine. Way back during COVID, the NICE guidelines has incorporated frailty, especially CFS, in triage for ICU admission. Then the latest article published its intensive care medicine in 2023 suggested that severity of frailty increases mortality and it is independent of age and acute illness. And if you have frailty, deconditioning, and okay, the internet is very poor. Okay, in summary, frailty is increasing, being accepted as part of assessment for older person in many clinical guidelines. CFS is a simple method to assess frailty with good correlation with outcome. One of the objective assessments for direction of care of critical ill older person is CFS. And CFS will assist us to individualize the management of all our older persons and provide a comprehensive shared decision making. Thank you.
Thank you, Prof, for your lovely talk just now. For the interest of time, we have one Q&A from on the chat box here. It's from Professor David Oregon. So the question is, many patients presenting for surgery would now be considered age. Example, aortic valve stenosis with the disease of the elderly. Do you think we should involve a geriatrician in the assessment and consent process, especially as it recognizes the decision-making of the elderly person frequently change? I worry that disease conveyor belts as experienced in the UK are not considering the whole patient, especially when prognosis after a certain age may not be convinced. So, Prof?
Yeah, I agree with Dr. Oregon with regards to the involving the geriatricians, especially in terms of counseling and also management. The multidisciplinary involvement, especially in frail older person, is advocated. Even in the guidelines, the pre-operative assessment guidelines, which I have mentioned to you earlier. And thank you for sharing that experience and statement. And we hope that it will also, I think it's still, it is happening here in Malaysia. but we would like more such multidisciplinary involvement so that to improve the management of surgical patients and also other older person in the hospital. Thank you.
Right. Thank you so much, Prof. Idzwan, for the very informative as well as very lovely talk just now. Thank you to all the participants and attendees for the talk. We'll now move over to the second talk. Over to you, Dr. Kong.